I'm a pediatric dermatologist in Bethlehem, Pennsylvania, and today I'm going to try to light a fire under you to think about not lasing nevi. Some relevant disclosures that aren't all that relevant. I'm affiliated with two textbooks that really don't talk about lasering nevi specifically, but we do talk about procedures in kids. So I'm going to start by just acknowledging the other side of this argument, that there are a couple reasons why you might want to laser a mole. First off, from a technical perspective, it might be a little easier than using a laser than using cold steel. You might have a little less scarring, and I'll be the first to admit it sounds pretty cool. If you could tell someone I'm just going to laser that mole off of you, both for the patient and for me, the user. But I'm hopefully going to impress on you that through this argument that this ain't whack-a-mole, and the decision that you make to laser a nevus or multiple nevi in a kid or adult or otherwise could be a life-altering decision. Just before I get started into the real argument for why you might not want to do this, if you are inclined to lase a nevus, I'm going to make a little statement here that you better consider at least two other aspects of this treatment. And I'm not proud of these clinical photos here, but this is a little kid that we saw. It was actually when I was training in pediatric dermatology out in San Diego. I was fortunate enough to train with Dr. Ross, who's actually in the audience today. And we applied, he and Doug Winstanley, his fellow at the time, came up with a novel and very effective long pulse Nd:YAG protocol to treat nevi. And the family had asked us to consider helping to lighten this young child's birthmark on his face. And you can tell it was working. It was working really well until the dad got a new job and moved to an area where no one in 6 hours would touch this with a laser or a 10-foot pole. So we just never finished the job. And to this day, I don't know if this came back and is more homogeneously brown or if it still looks like I started to laser it and didn't finish. So you gotta, if you're gonna do it, you better do it well. Also, you gotta expect some of the unexpected results. This is Serene Jin. I saw her when she was about 4 months old for the first treatment and utilized the same protocol on her, trying to take care of this large congenital nevus on her face as much as we could. And we were about 6 treatments in when we started noticing, hopefully it comes through on the PowerPoint there, but wherever we lasered and wherever the lightning was occurring, she was starting to develop deep rugations, for lack of a better word. And eventually we just had to say, this isn't doing anything except making things worse. No harm, no foul. Ultimately, she just went back to plastic surgery where they did the tissue expanders and she had the surgery and looks amazing. But this is not something I consented the family to because I didn't know it was going to happen. So if you're going to do laser for moles, you should expect sometimes that the results don't go as you intend. Now I'm going to make the argument using the 3 most common reasons that we hear about why you shouldn't lase moles. 1, the risk of malignant transformation. 2, the idea that you might actually be treating a melanoma and not know it. And 3, the difficulty that there is when you remove the surface of the lesion, unless you get it all, then how do you surveil after you've treated it? So let's tackle malignant transformation first. This is the idea that you start with a benign nevus, you put some energy into it, and you turn it into a cancer, okay? This argument starts by understanding your baseline risk for melanoma developing in an acquired nevus. So it's actually pretty low, 0.0005% or less for men and women under 40. And I'm going to assume for the sake of argument that that's the population that might most want you to laser some moles. Where does this information come from? Lasers in Surgery and Medicine article that Rox Anderson, Ash Margood, one of the world's best nevi experts, myself, Anthony Rossi, who's actually supposed to give this talk today but couldn't make it, and Tova Rogers did. So this is pretty low risk. How about lifetime risk? You're a 20-year-old, you got an acquired nevus, and you live to your 80. What's the likelihood that one nevus you pick turns into melanoma over that time period? Also pretty low, 0.009% for women. Congratulations, you're healthier than us. Men, 0.03%. So pretty low. That's baseline risk. Now, I'm not talking about large congenital nevi like the bathing suit distribution nevi. We know the risk for melanoma in those lesions is much higher, anywhere from around 5 to 10%, we think, okay? And speaking of what we think, there is some literature out there that suggests not just energy-based devices, but even cold steel might be contributing to this risk of malignant transformation. Where that comes from is that Dr. Kinsler out of Australia has published on several articles with this sort of suggestion in mind. The truth is that on a day-to-day basis, moles get lasered all the time. Right? Here's a guy getting his hair removal on his neck. He already had his sweet chest done, and you can see there's some moles there on his chest. So unless the person was really careful, they just went over these things. And what happens? Well, some case reports have showed exactly what you might expect. Moles actually tend to get a little smaller clinically, and if you look under histology, you'll see some thermal damage. You burned them a little bit. Okay, no big deal. Actually, Dr. Dover was in the room before the fire alarm went off, and his group did this great systematic review, also Lasers in Surgery Medicine 2023, suggesting and finding the same thing. And then 3 prospective studies said the same thing as well, looking out. There's some clinical changes. The moles tend to get a little smaller. Dermoscopically, they get a little hairy looking, okay? You have to, oh, wait, are these things turning bad? Give it time, and they go back to normal, all right? And looking out over long-term horizon, 8 years, moles that have been lased and then biopsied, under the microscope, no evidence of malignant transformation has been found in the longest study I could find, which is this 8-year. And that's kind of like in keeping with what we think we know. There are no documented cases of direct malignant transformation. And as of like last week when I spoke to him, Ash Margoob has still confirmed that he has never heard of a direct link. Okay? So I'm actually going to argue that that risk of malignant transformation is not a reason not to lase nevi. I'm taking that off the board. How about the risk that you might be lasing a melanoma and not know it? Well, again, let's remove the crazy stuff, dysplastic nevi, Spitz nevi, BAP1 deficiency. We're not talking about weird moles. We're talking about just regular acquired nevi here. We know, even as board-certified dermatologists, it might be a little tricky sometimes to guess what the melanoma is. But for us, what's been the real game changer, I'm going to argue, is dermoscopy. Okay? And there's this great study by Altamura who showed that 90% of melanomas in the first 3 months that they present will undergo dermoscopic change. Okay? I'm going to argue that you can use that fact to mitigate your risk. The idea that instead of maybe consulting the patient and then doing the procedure on the same day for the mole that they want off, could be done such as this. Take the pictures, clinical photos, dermoscopy photos that first day, have them come back in 3 months, look again. If there's no change, you can rest pretty assured that you're not dealing with a melanoma. So I'm going to even take that reason off the table for not lasing moles. But what that leaves is issue number 3. And it comes down just to the fact that we're not that good at removing all of the moles using energy-based devices. In fact, here's an article in 1999 from Rox Anderson. He's a better laser surgeon than I am, and it's in the title, right? Failure to completely eliminate nevomelanocytes. And guess what? Jumping ahead to 2018, this study looked at multiple different lasers. That last one was Ruby. Multiple different lasers, all gave the same results. Not great. We're not good at removing these. There were 11 patients that had more than 3 years of follow-up in this study. 5 of them had repigmentation more than 4 years out. So that's slow-growing, indolent repigmentation that you have no idea what's going on in that area. And that's the point, right? So unless you can remove the entire mole, all you're doing, as far as I'm concerned, is reducing some of the nevomelanocytes, and maybe, I'm not even going to give it to you, but maybe you're reducing the tumor risk. What I'm absolutely positive you're doing is you're removing the one thing that I've got as a clinician to monitor in terms of progression to melanoma, and that is change. And I want to make the point here that clinical change does not mean, if there's no clinical change, that does not mean there's no histological change. How do we know that? It's one of the coolest studies I've actually ever seen because it was selfless when it was published. This is Ash Margoob and 15 pigmented lesion centers across the world. They actually got together and published what I'm going to describe as probably the medical malpractice attorney's dream, that there's exhibit A through Z, right? They took pictures of what turned out to be slow-growing melanomas over more than a year. These were still on the person's body. They took clinical photos and they took dermoscopy photos, and eventually they figured out these were melanomas, took them off and removed them, and then went back and looked at the photos. And what they found was 2 things. One, from a clinical perspective, the moles didn't change very much. There wasn't a lot that the naked eye could detect for these changing moles. What was more important And what was universal was that all of the moles changed dermoscopically. And they decided, looking back at those photos, that, hey, we probably should have caught this. Okay, so it's kind of cool that they published it. But here's the point. If you're not getting the entire mole off, and you're ablating or removing the surface of that mole, that tip of the iceberg, you just removed it. So I can't see anything to tell you if this mole is changing or not. So in summary, I love the idea that we might use an energy-based device to treat a moles, but we're just not there. Do I think that malignant transformation is real? No. We would have heard of it by now. I don't think it's a thing. Am I worried that a board-certified dermatologist is going to miss a melanoma? Maybe, but with dermoscopy, you can mitigate that risk. For me, the hard stop is, geez, I can't surveil these lesions anymore if you've partially destroyed the surface of them. So if you are so inclined to treat moles, I would suggest using a patient population that's at low risk, making sure there's no clinical growth to these moles as well as any dermoscopic change, and make sure that you're not picking a thick lesion like a congenital nevus. Those are going to be going deeper south than any energy-based device that we have that really takes these off completely. The good news is Dr. Sakamoto was here earlier. Her lab with Rox Anderson, they're working on using cryotherapy to actually treat moles, so maybe that'll be a better approach. It's not there yet. And so I'm going to leave you with, if you're going to think about this, if you're thinking about still lasing moles, I would suggest that you do reach out to your malpractice attorney, see what he or she thinks. And if you suffer from Catholic guilt like I do, maybe you want to talk to your priest or rabbi, because you are definitely making a life-changing decision when you take a laser into your hands and treat moles. Thank you.